Welcome to Med One Pager. My name is Benjamin. Today I'm going to talk about the appendix. But interestingly, the appendix has been one of the organs that has been studied extensively by very many people. One of the famous artists, Leonardo da Vinci, in around 1508, came up with the first anatomical drawing of the appendix. Vesalius, also a renowned artist, was able to produce an image of it. And it was also the condition, appendicitis was the condition that is believed to have claimed the life of the escape magician that was Harry Houdini, that is in 1926. So my first day in the surgical rotation in med school, we were told this story of Dr. Leonid Rogozov, and this was a Soviet surgeon who removed his own appendix while he was stranded in Antarctica in 1961. So it was around April in 1961. The doctor was on a ship. It was during a Soviet expedition in the Antarctic, and that was between 1960 and 1961. And he was the only doctor that was in the station by then. So one morning he wakes up and feels general weakness, nausea, moderate fever, and later he develops pain in the right lower quadrant. And being a surgeon or being a doctor, he knew that this was appendicitis right away. But he knew this, but could not actually be able to come up and tell any of his friends about on the station because none of them were doctors. So in his own words, he wrote in his diary that it seems I have appendicitis. I am keeping quiet about it, even smiling. Why frighten my friends? Who could be of help? A polar bearers, a polar explorer's only encounter with medicine is likely to have been in a dentist's chair. So he continues to be through the pain. He can't sleep at night. He feels a lot of pain. And then he realizes that if he does not do something about it, he may maybe lose his own life. So at around 2 p.m. Local time, that is the time where they were, with the help of his friends, he gets together and they give him the instruments. They prepare an instrument tray for him and also put a mirror for him. So his friends were all there taking pictures of him while he started to do this appendicectomy on himself. And the operation lasts about one hour and 45 minutes. And in between the procedure, he would feel dizzy, he would get vertigo, and it reached a point where the mirror was even becoming a hindrance because the mirror is showing in reverse, and then he was struggling to also look at the mirror, holding his head up. So he reached a point, and Rogozov decided to just continue the operation blindly by touching and feeling whatever was inside there. So as he was entering the peritoneum, he went into the cecum and cut through the cecum, which he had to again suture before going on. Then he finally was able to promote to do the appendectomy, where he found the base of the appendix had some gangrenous part on it at the base. He removed it, put antibiotics in the peritoneum, sutured it, and covered. So that is the story of Dr. Rogozov. And then every time I'm thinking about appendicitis, I go back and think about it and I say, I would not do that. I would not operate on myself like that. But he did and survived and lived until 2000, where he succumbed to lung cancer. That is in St. Petersburg in Russia. So when we look at appendicitis is basically the inflammation of the vermiform appendix, and this is the most commonly going to be due to luminal obstruction, or used to be most commonly due to luminal obstruction that leads to ischemia, bacterial overgrowth, necrosis, and then possible perforation, and the perforation leads to peritonitis that eventually leads to death. So embryologically, when this appendix is developing, it is formed as a true diverticulum of the cecum. So remember, at the cecum is like at the beginning of the large intestine, where the ileum joins the large intestine. So at that point, there is a diverticulum that is what is going to form the appendix. So it develops from the midgut, and it has lymphoid tissue. Now the lymphoid tissue develops, and it's going to peak at around the second to third decade there. So you'll find that most people who get appendicitis are going to be between the years of 20 and 30 years of age. Then the appendix is supplied by one end artery, and this is important anatomically because It means if this one arterial supply is affected, the appendix is going to lose blood supply. And that is why if there is going to be rapid progression of necrosis. And then we have some embryological abnormalities where we have duplication of the appendix. In type 1, where the cecum is okay. In type 2 or type B, that is when you have 2 appendix but on 1 cecum. Then type C is where you have 2 cecum with 2 appendix. Then we have conditions like cytosynthesis, where the organs inside the body have changed the position. The left are on the right and the right are on the left. That can be very important to keep in mind, because sometimes if the appendix is on the left and you don't know that, then you may not be able to diagnose appendicitis. Then you have subhepatic appendix, where appendix is behind the liver. So positions, normally we have the retrocecal, and this is the most common, and that's 60%. And complications that you have retrocecal appendicitis, most of the time we're going to have flank or back pain and inward emanence. When it's in the pelvic position, we're going to have urinary frequency, tenesmus, and diarrhea. If it's pre-ilio, that is in front of the ilium, that is 1%, it's going to cause vomiting prominently because of the irritation is going to cause these pyloric spasms or cause the vomiting. Then it can be post-ilioate behind the ilium, and that is going to be most of the time going to give you severe pain and add the obstructing signs because of a paralytic ileus. So look at the etiology. Many things have been tried to follow, but race and diet have been a very big argument when it comes to causes of appendicitis for a long time. So the Western diet, which is low in fiber, has been implicated, as well as red meat. They found that diet is protective, and nowadays it has been found that actually the trend is changing, that the whites are having less of this appendicitis occurring, and they're attributing it to the use of antibiotics in a long while. And the blacks, or in the Western, in the African American or the African community, there is westernization of the diet where people are going for less fiber foods more often, and this has led to the increased occurrence of appendicitis. So we have a familial whereby we have a long appendix, and we remember appendix is supposed to be it's going to be supplied by one artery. So if that artery is the distal part of the appendix that is further and further away from that artery, it's going to have a decreased blood supply, and that may lead to the cascade that starts the appendicitis. Then we have the obstructive theory, where we have things obstructing the lumen and trapping things into the appendix. You can have a fecal leak, you can have worms over, or just the lymph tissue that is inside there, which is part of the gut lymphoid, associated lymphoid tissue. So if this tissue expands, or we have a viral infection and it expands, it can lead to obstruction, and that's going to cause appendicitis. Then we have non-obstructive causes, and that is what we call the Katahara appendicitis. Appendicitis is not due to obstructive causes. So basically, you just have an infection, that inflammation of the appendix, and you end up with appendicitis. And the most common organism implicated is going to be the E. coli, which is very, very present or highly abundant in the gut. Then the clinical presentation, we have a pain migration, which is going to be around in 50 to 60% of people, and the pain is going to begin at the umbilicus, and then it will radiate to the right lower quadrant. So when it begins the umbilicus, I'm not going to say it here. I would like to see what you think about that in the comment section. Please do comment, and I'll be answering, and I'll also give more clarity on that in the comment section. Then anorexia is one of the most important features. Most of the people with appendicitis will not want to eat because of this anorexia. Then vomiting can be present. Then they can also have fever. Then we have some atypical clues where someone may have diarrhea. This can be due to a pelvic appendix. Someone can have dysuria, which is due to bladder irritation when the appendix goes to the pelvis. We can have right thigh pain, and the psoas muscle is involved. And then the pain can sometimes be temporarily relieved. And when the pain is temporarily relieved, sometimes the patient thinks they're getting better, but when actually what has happened is that they've had perforation. And this is a dangerous false reassurance. So when we look at the clinical signs that are seen in these patients with appendicitis, one of them is the Dunphy sign, which is a cough tenderness, whereby when the patient is asked to cough, they're going to feel pain in the right lower quadrant. And this is because when they're coughing, there is movement of the parietal peritoneum, and when you move the parietal peritoneum that has the sensory nerves, are going to feel pain. Then tenderness is just pain in that area which is untouched. Then we have rebound tenderness, whereby when you put some pressure and gently push in that part and release instantly. Because of that vibration of the peritoneum, you have some pain, and that is normally called the Bloomberg sign. Then you have the Rovsing sign. The Rovsing sign is when you put pressure or you push on the left lower quadrant. When you push on the left lower quadrant, and release. When you push on the left lower quadrant, you move the gas and the intestines, so they're going to move, and they will try on the right side. They're going to cause movement of the appendix on the peritoneum, which is going to cause that irritation, and the patient is going to feel pain in the right lower quadrant. So you press on the left lower quadrant, the patient feels pain in the right lower quadrant, and you have the obturator sign where the patient is told to lie down on their back, and then they are flexed at the hip as well as at the knee. Then you try to internal rotate. You try to move the knee inwards or towards the midline, and that is going to irritate the psoas internal muscle, and they're going to feel pain. Then the psoas sign is when you try to hyperextend the thigh and they're feeling pain in the back. That is because the appendix is irritating the psoas muscle. Then you have hyperthesia in the area in the Sharon's triangle. Now I'm not going to talk about the Sharon's triangle, but you can Google and see the demarcations of the Sharon's triangle. Then you have tenderness of vagina on a vaginal or rectal examination. And investigations that are important, one is the total blood count, and normally we're going to see a leukocytosis, and the leukocytosis here is going to have a right shift. So there is a right shift on when you do the leukocyte count. Then you can do a urinalysis to rule out other things. You want to do C-reactive protein and procalcitonin. Then again, you want to rule out all other possible differentials of appendicitis, and we're going to look at the differentials as the video goes on towards the end of this video. Then imaging, ultrasound is going to be first line in children and in pregnancy, and most of the time what you see on ultrasound is that we have an uncompressible appendix with a diameter greater than 6 millimeters, and the ultrasound is going to be operator dependent. So sometimes the sensitivity or the specificity is going to quickly fall or increase depending on who is doing it. Then we have the CT scanner. This is regarded as the gold standard for diagnosis of appendicitis, especially in adults. And we say it has a sensitivity of about 95%. In the findings, we're going to find an enlarged appendix. The wall is going to thicken because it is inflamed. We have fat stranding. You may find an appendicolite, which is a mass within the appendix. This could be due to impacted feces. Then you can find an abscess or a perforation. Then in pregnancy, you can do an MRI if the ultrasound is inconclusive, because you don't want to expose that child to ionized radiations. So these are the signs we looked at. That is the psoas sign where they do the hip extension, the obturator sign where you do hip extension and the internal rotation of the foot and you have pain. Then the Rovsing sign where you press on the left of the abdomen but you feel the pain on the right. Then we have some scoring systems, and these are very, very important both on exams and clinically, because after getting these signs and symptoms, the Alvarado score is what is going to tell us if we are most likely dealing with the appendicitis or not. So the Alvarado score, the parameters are always abbreviated as MANTRA, where M is for migratory pain and we score it as 1, no anorexia or 1, nausea and vomiting as 1, and then tenderness in the right lower quadrant is going to carry a score of 2. Rebound pain is going to score 1, elevated temperature is going to score 1, then a leukocytosis is going to score a 2. So a patient with appendicitis, most of the time is going to have a leukocytosis greater than 10,000. If they do not have a leukocytosis, most likely they do not have appendicitis. And when it goes above 20,000, they are most likely having a perforation at that point. Then we have a shift to the left, and this is going to show that there is increased production of the new white blood cells. So it's going to be a shift to the left. You can read up more about it. Then we have a score interpretation. So if a score is less than 4, it's unlikely going to be appendicitis. 5 to 6, you want to observe, it is likely appendicitis. Greater than 7 is likely appendicitis. When you have a score of 9 or more, then this is truly appendicitis. Then you have another classification system where you can classify it into simple or complicated appendicitis. Then we have the AAST grading, where the grade 1 has inflamed, grade 2 gangrenous, grade 3 perforated with contamination, grade 4 abscess, and grade 5 and peritonitis. And this is basically the stages or the pathology that the appendix goes through in appendicitis. So it first become inflamed. When it become inflamed, because of that luminal obstruction, pressure is increasing. It's going to lose the blood supply due to compression of the venous system and everything. And then perforation will ensue. Then an abscess can occur, as well as diffuse peritonitis. So complication of appendicitis, we are going to have a perforation, appendicular abscess, appendicular mass, psoas abscess, a liver abscess, because as the patient is breathing in and out, they are going to have this suction by the diaphragm, and sometimes it pulls the contents or the septic contents upwards. That is if they have not yet been walled off. Then we can have a bout of phlebitis and then a septic shock. Then in some special populations like the children have a poorly developed omentum. So when you have a perforation most of the time, or this infection, the greater omentum is going to try to contain it in the right lower quadrant. It's going to contain it down rather than prevent it from spreading to the rest of the body to cause the generalized peritoneal infection. So in children, it's underdeveloped and they have high risk of that. Then perforation is also more common in children. The intestines are still thin, and then the gut is underdeveloped. Then they have fever and diarrhea more commonly, and this is going to mislead. And we have a diagnosis of gastroenteritis, which is going to be a misdiagnosis. Then in the elderly, they have a blunted inflammatory response and there is a high mortality, and it often presents with complications. So most of the time it's going to be a complicated appendicitis. Then in pregnancy, the appendix migrates upwards, and leukocytosis is unreliable because it can be physiologic. And then delayed surgery has been found to increase the chances of fetal loss in these people. So whenever we have an appendicular mass, or whenever we have to do conservative management in appendicitis, it is very important that we consider the ocean and sharing regimen, which was a series of conservative rules that were made to manage this appendicitis without surgery. And you'll find things like aspiration when you want to decompress, so you do aspirate the patient with a Ryle tube. If you want to start a bowel rest where you give the patient nothing by mouth, that is neopaos, and no laxatives, because laxatives can lead to perforation. Then you want to chart the patient's vitals, temperature, pulse, respiration, as well as the diameter of a mass if they have a right lower quadrant mass. That could be either an abscess or that could be an appendicular mass. Then you want to give drugs that cover both for the aerobic and anaerobic. Then you want to do an X-lap if they are not improving, and you want to give fluids that is going to be intravenous fluids. So when we look at the surgical treatment of appendicitis, the definitive treatment in a complicated and uncomplicated appendicitis is always going to be the appendectomy. However, in uncomplicated appendicitis, they found non-inferiority to the role of operative to non-operative methods. So, which means that when someone has appendicitis, you can choose to manage them operatively or non-operatively if it is uncomplicated. And they found that even the non-operative group was able to have a full recovery. But the things that you have to note that those ones who are done who are managed non-operatively, they had high recurrence rates compared to those who are operative because the appendix is removed. And then these ones who are non-operatively managed to have a longer stay on the hospital because, of course, you are having issues because the appendix, the source of infection, is left there in situ. Then we have the timing of the surgery. Sometimes it's an emergent if we do it in less than 12 hours. And sometimes it's not if you do it more than 12 hours. And I found that when it was done within the first 12 hours, there was non-inferiority, or the outcomes were similar to those that were done greater than 12 hours. But those that had it early, within the first 12 hours, they had a longer hospital stay. So those ones greater than 12 hours, so most of the time it's permissible to let them, if a patient comes within 48 hours of onset of symptoms, you can leave them for the next 12 hours, and then you give them antibiotics, resuscitate them, you do the preoperative preparation very well, then you continue to do the operation to remove the appendix. So the complicated appendix, perforation, when a patient had a perforation, you can approach that operatively or non-operatively with image-guided percutaneous drainage as well as antibiotics. So non-operatively will be the ocean and saline regimen. Then when we have an appendicular mass, so an appendicular mass is going to occur when we have this infection and the infection is sealed off by the omentum. So it's going to form a tender, soft, firm mass in the iliac fossa. And most of the time when you have this mass, it is a contraindication to surgery, because once you do surgery in that place, there's a lot of inflammation going there, there's a lot of things happening. You may risk the patient getting an enterocutaneous fistula where they will start having fecal discharge through a fistula that you form in that region. So most of the time we want the mass to first go down, and then we do the surgery only and only if the patient is not improving or we suspect there's an abscess, because once you have an abscess, you have to remove the principles of management of abscess are most of the time precision and drainage, but in this case you have to always drain the abscess. So when you have an appendicular abscess, now how do you know the patient is going to come in with a high grade fever? They're going to have chills, they're going to have rigors. Whenever you see high grade fever, chills, rigors, think about an abscess somewhere. Not just an appendicular abscess, but all abscesses are going to cause this kind of presentation. And the abscess can be retrocecal, periidial, ostilial, pelvic, subcecal. Sometimes it can go to the hepatic and becomes an hepatic abscess. So now we look at the Valentino appendix or Valentino syndrome, and this not only is not a true appendicitis, but what happens is that someone has another condition. Maybe someone has a perforation of the duodenum, and then the contents are going to move along the paracolic gutters. These ones are the gutters, or the free space between the besides the colon. So as they move across these paracolic gutters, they're going to eventually go and collect in the right iliac fossa, and this is going to cause pain in that area that resembles like someone is having an appendicitis. That's called the Valentino syndrome. Then we have the really wide appendix, or the normal appendix, or the negative exploration. This is when the surgeon goes in to find and to remove an appendix, and they are thinking this patient probably had an appendicitis. But when they reach there, they find that the appendix is normal, and the normal appendix is going to appear white, which is why it's called the really white appendix. So what happens is that the surgeon is going to remove this appendix so that we avoid confusion next time this patient goes to the hospital, because the doctor may see a scan showing the appendix is out, the appendix is in. So normally we remove it, and then you have to check for other differentials that could have given you the reason to do this exploration. So you have to check 2 feet from the cecal junction for the mucous diverticulum, and you want to check for mesenteric lymph nodes. You want to check the ovaries and fallopian tubes. They could be twisted, there could be anything like that. Then you want to check on the gallbladder as well as duodenal ulcers, because all these can mimic an appendicitis. Then we have the complications of surgery after appendicitis. We have the early and the late complications. We can have the localized, but we can have a localized peritonitis, can become generalized. We can have appendiceal perforation, even at the stump where you covered it can perforate again. We can have a paralytic ileus, septicemia or bacteremia, potopaemia, where we have, remember, the appendicular vein is going to fall into the splenomesenteric, which goes into the hepatic portal vein. So you can have a potopaemia or porphyrophlebitis, which is inflammation of that portal vein, then wound infection. Then late complications, you can have appendicular mass, appendicular abscess, adhesive intestinal obstruction, recurrent appendicitis, incisional hernia, post-appendectomy, then a fecal fistula. Then we can have chronic right iliac fossa pain. Then we have some differentials that are very important, and I put this at last because it's something that is very important to remember, because if you don't consider these differentials enough, you may go in and cut a patient who does not deserve to have surgery done on them. So the group, we have the children, the females, and the adults. So in children, most common differentials are mesenteric adenitis, gastroenteritis, intussusception, mucous diverticulitis, constipation of urine infection, then lower lobe pneumonia, and Henoch-Schleien purpura. Then in females, you can have an ectopic pregnancy, ovarian torsion, ruptured ovarian cysts, pelvic inflammatory disease, endometriosis, metochimas. And metochimas is important. Metochimas is this pain that a patient, the woman experiences intramenstrual. So it's going to occur within the menstrual cycle before they are supposed to have their periods. And this is because due to rupture of due to release of the egg from the from the release of the ova. So as it releases, there's some little fluid that comes, and that fluid causes some irritation. Then you have tubal ovarian, a tubo-ovarian abscess. This could also come when the patient had a PID before. Then adults, a gastroenteritis, ureteric colic from the ureters. We have the right-sided diverticulitis, Crohn's disease, sickle carcinoma, perforated peptic ulcer, and psoas abscess, as well as cholecystitis. So we have come to the end of this video where we have gone through very many important aspects when it comes to the management as well as the treatment of appendicitis. I hope you liked the video. If you did like the video, I would like you to subscribe to the channel, leave a like, as well as a comment. And then don't forget to watch my other video. I made a video about obstructive jaundice. Please do check that out.